My dear viewers, Assalamu alaikum. Today I like to discuss one of the most important childhood arthritis, very much important in our daily practice. It is most commonest rheumatic disease of the children and one of the most important chronic illness in the childhood. American College of Rheumatology's name was Juvenile Idiopathic Arthritis once, but after 1995, the nomenclature changes to Juvenile Idiopathic Arthritis by International League of Association of Rheumatology, changed the name. And another name, European League Against Rheumatology is nomenclature is Juvenile Chronic Arthritis. But World Health Organization accepted Juvenile Idiopathic Arthritis. Remember this. Now I like to say how the patient is present to you. What the clinical manifestation of the patient. Now first of all, age is in between 2 to 4 years of age. Then arthritis. Arthritis may be defined as intra-articular swelling with presence of 2 or more of the following criteria. What are the criteria? Limitation of range of motion, tenderness, pain on motion, increase heat, local temperature will increase. This is the definition of the arthritis. Remember this. Now I like to highlight about the juvenile idiopathic arthritis. It involves both the small and large one. Remember this. It classified as oligoarticular juvenile idiopathic arthritis. It is about 40 to 50%. It is in two types. One is persistent oligoarthritis. It is less than 4 joint involvement, and persistent and extended oligoarthritis. It is more than 4 joint involvement in the first 6 months. Next is polyarticular arthritis. It is about 25 to 35%. It has even two types. One is rheumatic factor positive polyarticular GIA and rheumatic factor negative polyarticular GIA, and it is percentage 25 to 30%. Next one is systemic onset GIA, 10 to 15%. The arthritis with quotidian fever for at least 3 years and accompany one or more of the following criteria. What are the criteria? Evanescent erythematous rash, lymphadenopathy, hepatosplenomegaly, and serositis is the clinical manifestation of systemic onset GI. Remember this. Next one is psoriatic arthritis, about 5 to 10%. Arthritis with psoriasis, at least 2 of the following criteria. What are the criteria? Dactylitis, nail fitting or onycholysis, and psoriasis are the first degree relatives. Next one is enthesitis related arthritis. It is about 5 to 10%. Arthritis with enthesitis with at least 2 of the following criteria. What are the criteria? History of tenderness of the sacroiliac joint, lumbosacral pain, presence of HLA-B27 antigen, onset of the arthritis in the male child more than 6 years of old, acute anterior uveitis, and history of ankylosing spondylitis. Last one is undifferentiated arthritis. It is not fulfill any criteria of the juvenile idiopathic arthritis. Now what are the pathogenesis? Very much important one is what are the pathogenesis? Pathogenesis, JIA, that is juvenile idiopathic arthritis, is an autoimmune disease with alteration of the both humoral and cell-mediated immunity. T cell play a vital role releasing the pro-inflammatory cytokine. Remember this one. All immunological abnormality causes inflammatory synovitis characterized by villous hypertrophy and hyperplasia, hyperemia, infiltration of the inflammatory cell, inflammatory cell, monocyte, plasma cell, predominant T lymphocytes. Advanced and uncontrolled disease leads to venous formation, which causes progressive erosion of the articular cartilage and contagious bone. Now what are the investigation? First of all, the diagnosis of the juvenile idiopathic arthritis completely it is a clinical diagnosis, but we did some investigation for confirmation and DD exclusion. Remember this. First of all, we go for complete blood count with C-reactive protein. incomplete blood count, WBC count will be increased, and there is a thrombocyte also, there is thrombocytosis, and there is also serum creatinine will be rise and increased C-reactive protein. Urine should be routine examination for to see the proteinuria and hematuria for the exclusion of the SLE, purpura, and acute glomerulonephritis. Now another one is antinuclear antibody should be it will be assessed, should be done for oligoarthritis, polyarticular types of juvenile idiopathic arthritis, and it is negative in systemic onset GI. Remember this. Now the rheumatoid factor should be done all polyarticular types of all follicular GIA and SOGIA also. NTCCB antibody should be the good serologic marker of early diagnosis of the juvenile idiopathic arthritis. Now the imaging. First all we do for X-ray of the affected joint to see the bony density and soil as a soft tissue swelling, joint erosion, joint space and different mortis. Now the MRI. MRI should be done to see the bony structure and cartilage structure. Then ultrasonography to see the intra-articular fluids. Finally, synovial fluid analysis and synovial biopsy should be done to see the tubercular arthritis. Arthroscopy should be done to see the penis formation. Now the management. Management is multidisciplinary approach. Management is multidisciplinary, which include pediatric rheumatologist, pediatrician, then orthopedic surgeon, ophthalmologist, occupational therapist, physiotherapist, dentist, nurse, and pediatric psychologist and nutritionist. All discipline is involved in this management of the juvenile idiopathic arthritis. Remember this. What are the pharmacological treatment? The pharmacological treatment is first we start with the NSAIDs, that is naproxen, ibuprofen, and meloxicam is the drug of choice. Next DMRD. These methotrexate, sulfasalazine, hydroxychloroquine, alaflunomide should be given as a disease modifying reagent. Now intra-articular stress should be given triamcinolone hexaconazole, and biological agent should be given for prevention of the production of the cytokine. TNF alpha, the TNF alpha protection, TNF alpha antagonist should be given etanercept, infliximab, and adalimumab. And interleukin 1 antagonist is anakinra, and interleukin 6 antagonist tocilizumab should be given. It's very much important drugs. Next, anti-CD20 antagonist rituximab should be given. Finally, autologous stem cell transplantation is the choice of treatment. And now the treatment of the uveitis should be local steroid and periodic split lab examination every 6 months. And treatment of the osteoporosis with vitamin D, calcium supplementation. Now what are the parents counseling? Counseling is the better. Parents counseling should be done about the natural history of the disease and its outcome. Should be explained the father, mother. It is a common chronic illness of the childhood. Waxing warning nature of the disease. Oligoarticular types of GIA prognosis is very good, but polyarticular and systemic onset juvenile idiopathic arthritis improvement is very poor, a poor prognosis, very much poor prognosis. Now what are the complications of the GIA? The complication of the juvenile idiopathic arthritis: joint contraction ankylosing with atrophy of the adjacent muscle, anemia, pericarditis, myocarditis, glomerulonephritis, chronic anterior uveitis, growth failure. This is the complication of the acute juvenile idiopathic arthritis. Thank you very much for patient hearing.